All right, future physicians, listen up. Epilepsy is a condition you are absolutely going to see on the wards, and knowing how to treat it safely and effectively, well, it's non-negotiable. So today we're going to walk through the whole process, from the synapse right up to the bedside.
So, to make this real, let's start with a patient. This is Katie. She's a super bright 7-year-old who came to my clinic. Her teacher was a little concerned because she was having these brief zoning out spells in class. She'd just stare into space for a few seconds, totally unresponsive. Her parents were worried, and you know what? They had every right to be.
We're going to use Katie's story to build a mental framework that you can take with you into your rotations. We'll follow her journey from that first symptom, dig all the way down to the level of the synapse, and then come back up to find her treatment solution.
So what is actually going on inside Katie's brain when she has one of these spells? I mean, to have any hope of treating her, we first have to understand the basic science behind what she's experiencing.
Okay, so what is a seizure? At its core, it's basically a brief electrical storm in the brain. It's a temporary, totally out-of-control burst of activity that just throws a wrench in the normal communication between brain cells.
Now, this is absolutely crucial. A seizure isn't just a seizure. We have to classify them. And the big question is, where does that electrical storm start? Does it kick off in one specific spot, what we call a focal seizure? Or does it light up both sides of the brain at once, what we call generalized? Getting that distinction right is the first and most important step because it literally dictates our entire treatment plan.
And that brings us right back to Katie. Her staring spells, that's the textbook presentation of a type of generalized seizure we call an absence seizure. It's a classic feature of certain childhood epilepsies. What her teacher saw as daydreaming was actually her brain's electrical wiring short-circuiting for just a few moments.
Okay, so we've got a diagnosis. Now for the big question. How do we actually step in and fix this? How do we restore the brain's electrical balance? Let's open up our therapeutic toolkit and see what we've got.
You know, when you get down to the nitty-gritty, down at the synapse, it really boils down to two main strategies. We can either turn down the brain's go signals by messing with excitatory neurotransmitters like glutamate, or we can crank up the stop signals by boosting inhibitory ones like GABA. That's the whole game right there.
This is precisely why picking the right tool for the job is so incredibly important. We've got our broad-spectrum drugs, kind of like a Swiss Army knife that works on lots of seizure types. And then we have narrow-spectrum drugs for very specific jobs. And you have to get this right because getting it wrong can make things so much worse. For example, if you give a narrow-spectrum drug for focal seizures, something like carbamazepine, to a patient like Katie, you can actually make her absent seizures flare up. So for Katie, our choice is actually pretty clear. Ethosuximide is a narrow-spectrum drug, and it's the absolute first-line treatment for uncomplicated absent seizures. It's perfect for her because it works by targeting the exact T-type calcium channels in the thalamus that are responsible for generating her specific type of seizure. It's a precision tool.
Now, Katie's case is a great example, but it's pretty clean. As you get into the clinic, you have to be ready for the really significant risks and the complexities that come with a lot of our other anti-seizure medications. This is where things get very, very serious.
I need you to burn this into your memory. You must never, ever forget the risk of Stevens-Johnson syndrome, or SJS. It's rare, but it is a potentially fatal skin reaction that we see with drugs like lamotrigine and carbamazepine. This is why our mantra, and your mantra, is start low and go slow. And you have to tell every single patient, any new rash is a medical emergency, they stop the drug, and they call you immediately. No exception.
And that idea that small changes can lead to huge, unpredictable consequences, well, there's no better example of that than with one of our oldest, most challenging drugs, phenytoin. It's a workhorse for sure, but man, it demands a ton of respect because of its really tricky pharmacology.
So look, most drugs follow nice, predictable kinetics. You double the dose, you roughly double the blood level. Simple. Not phenytoin. It uses something called zero-order kinetics. What that means is the liver's ability to break it down gets saturated. It gets maxed out. And once that happens, even a tiny little increase in the dose can cause a massive, totally unpredictable spike in the drug level, pushing your patient straight into toxicity with almost no warning.
And it's not just the kinetics that are a headache. On top of all that, long-term use of phenytoin is notorious for a whole constellation of side effects. We're talking about things like gingival hyperplasia. That's a fancy term for overgrowth of the gums. Hirsutism, which is unwanted hair growth. And it can even cause thinning of the bones over time.
As if that wasn't enough to worry about,
A lot of the older anti-seizure drugs, including phenytoin, are famous, or maybe infamous, for creating a minefield of drug-drug interactions. They do this by messing with the cytochrome P450 enzyme system. That's the liver's main processing plant for just about every medication out there.
So you basically have two kinds of players here. You've got the inducers, like carbamazepine and phenytoin. They hit the accelerator on drug metabolism, which can make other drugs totally ineffective. Just imagine your patient whose oral contraceptive fails because her seizure med chewed it up too fast. Then on the flip side, you have inhibitors like valproate. They slam on the brakes, slowing metabolism way down, which can cause other drugs to build up to toxic levels. You have got to check for these interactions, every single time.
Okay. We have covered a ton of ground here, from synapses to scary side effects. So as we start to wrap up, let's distill all of this complicated pharmacology into a simple compass, a set of guiding principles you can actually use when you're standing there in the clinic.
These 6 principles right here, this is your foundation. 1. Diagnose the seizure type first. Everything flows from that. 2. Aim for monotherapy. Use one drug if you can to keep things simple and minimize side effects. 3. Start low, go slow. We just talked about why. 4. Treat the patient in front of you, not just a number on a lab report. 5. Educate and empower your patients. Make them a partner in their own care. And 6. Last but not least, always anticipate drug interaction.
So when you walk onto the wards and you meet your first patient with seizures, I want you to remember these principles. Your knowledge, your caution, and your compassion. Those are the tools that are going to keep your patients safe. The well-being of your own Katie's is going to depend on it. Now, go make a difference.